everybody. Welcome back to another episode of The Skeleton Crew. I'm your host, Jen Callahan, and today I have a great guest with me. His name is Chris Clarke. He is a consultant radiologist at Nottingham University Hospital, which is located within England. So he's joining me from across the pond. He's got a wealth of different knowledge in GI imaging, hepatobiliary, and emergency. And then he's got his hand in a bunch of extracurriculars that, I'm interested to talk to him about. So, Chris, thanks for being with me today.
Thank you. It's wonderful to be here.
So I first want to ask, consultant radiologist, is that a term that's used in Britain or in England, or what exactly does that mean?
Yeah, so I guess you call it, is it equivalent of attending, I guess? You head the team up, basically. Yeah, so we all call consultants in England, and then in the community, general practitioners. And then our trainees are called registrars. So yeah, the terminology is slightly different, but yes.
Right.
I've been a
Okay.
consultant for 5 years.
All right. That makes sense now. Thank you. So while we're talking about, since you are attending and you have the registrars underneath of you, the trainees, I kind of want to jump off with this website that you put together called radiologycafe.com, and it's for students who are out there. Is it for the students who are looking to get into radiology, or is it students who are currently in radiology and then for them for when they're leaving?
It's a bit of both. So yeah, initially I started it in 2011. And back then, there was nothing really for people applying to radiology to know what the process was or how to get in. So I just basically I went through the process and the interviews, and I put all the information on about how the UK system works on there to help people. And that was really useful. And then as I went through my training, I added on more and more learning resources. So now it's got sort of mock exams for our radiology exams in the UK. We have a Royal College called the Royal College of Radiologists, and that's who we all kind of register under. And all the trainees have to pass the Royal College of Radiologists exams. So
Okay.
there's anatomy and mock questions and some physics stuff online as well, which I've added
Okay.
to the website. So
That's definitely, like, super helpful. I remember doing mock exams for myself, becoming like a rad tech. So I can only imagine how much more in depth, obviously, the boards that radiologists are taking and how I'm sure useful something like that is for students. You're so nervous taking these tests that as much as you can prepare yourself is really what you need to do.
yeah, no, definitely. We have two exams at the beginning of training, anatomy and physics, and that's what my website concentrates on. The anatomy is fun and easy, and I've got lots of mock questions, but the physics is hard, and I'm sure you guys have to do physics as well, and it's a lot of facts and numbers and things. And so I did the anatomy, but I worked with a colleague, Sarah Abdullah, who wrote some really good physics notes, and I kind of reached out to her, and then we kind of linked up and put her notes on the website as well. So
Okay.
yeah, it's nice to share them with people.
And when you talk about physics, are you talking in terms of like the patient, or do you mean with like the radiology equipment?
So ours is mainly radiology equipment. It's about, it's the physics of X-ray, CT, MRI. There's nothing in our exams really about patient positioning and things. That's much more sort of radiographer. So yeah, we don't really learn that in great detail.
Yeah, I remember the physics. Did you have to learn about generators and the currents and physics that you're talking about? Okay, yeah. I mean, I have
Yeah,
to say,
Compton, all that. Yeah.
I remember it. I remember learning it. I could not repeat it back to you right now because I
Yeah,
feel like once
same.
I took I feel like once I took my exam, it sadly went out of my head.
Yeah, there's knowledge and then there's like working knowledge, isn't
Yes.
there?
Yes. So Radiology Cafe, obviously, you said is helping to prepare students. Do you also help them in other senses, maybe like helping them find a job, or do you have other colleagues that help post on the cafe site about institutes that are looking for new doctors?
So it doesn't do that. I did think about it, but there's better websites out there that do that. So I'm not trying to kind of rewrite, fantastic websites already doing that out there and try and do it again. But it does have advice on when you're applying for consultant jobs, like mock interview questions that might be asked, where to apply, some advice on kind of setting up your job. So kind of more general advice, but it doesn't have like specific job adverts. I did put some stuff for medical students on there as well, which I think certainly we get people from all over the world looking at that, including America. It's called Radiology Basics, and it's basically like a really basic overview of CT, X-ray for medical students. Pulmonary embolus, this is a diverticulitis. This is kind of a few basic pathologies with some explanation. So it's quite simple, but it's quite a nice little overview.
Mhm.
So I put that on there because that's quite helpful.
Yeah. And especially too, like you said, like mock interview questions and things like that. So sitting for an exam, your heart's pounding, you want to try to be as prepared as possible, but going out for your like almost like real first interview for your new profession probably has your heart racing and stuff. And so many different places conduct their interviews differently. Some people are very scripted and have questions that ask you, and they're going down and they're checking off the questions that they have to ask. And then other places kind of just want to get to know you as a person, and then, might be talking about the career or the position itself like intermittently through it. It's kind of more like conversational based. So either way, again, being prepared is name of the game for newbies, I feel like.
Definitely. And actually, it's interesting. In the UK, it used to be, when I did it, you had interviews at each individual sort of area.
Okay.
And now it's all nationalized. So actually, in the UK, the last few years, it's all been centrally coordinated. And interviews, I think since COVID, moved on to Teams as well. So it's all online and it's fairly scripted now. So everyone gets the same experience. They have to to get into radiology, you have to do an exam. And then you're prioritized based on the exam. And then you have the interview. So it's quite a big process. Yeah, I tried to keep the website up to date with all the changes because it's changed a lot since I applied.
And how long have you been practicing?
I've been a consultant for 5 years. I did my trade, finished med school 2009, and then I did a few years of junior doctoring, and then radiology training from 2011 to 2016. Then I did a fellowship at one of the other hospitals in the UK, Leeds. It's a very good centre for GI. So I did a year there, and then went back to Nottingham to been a consultant in Nottingham for the last 5-6 years.
All right. So
Yeah.
let's talk about Nottingham then. Is it a fairly large hospital that you're
Oh,
at?
it's big. Yeah. I think so. There's two hospitals in Nottingham. One's called the Queen's Medical Centre, and it's a huge building. I think at one point it was one of the largest in Europe. It's a huge complex. It's like 5 squares. From above, it's like 5 squares all interlinked. But it's
Okay.
a bit of a maze. It's like I get lost in it. Colleagues get lost in it that worked in it for ages. It's just massive. We're a major trauma centre for the region, so we see a lot of trauma. A lot of we've got our main motorway for the UK running close by for a lot of car accidents and horse. So we do a lot of emergency imaging. But we're a tertiary referral centre for a lot of cancers, and we're a neuro radiology kind of specialist, sort of quaternary centre. We do sort of national NDTs on the neuro side. So
Okay.
it's very specialist there. That's not me though. I'm GI. So I'll let my colleagues sort that out.
What drew you to GI that you wanted to specialize in that?
It's the clinicians, I think.
Okay.
So it's interesting. You go through training, and with some specialties, you don't have as much interaction with the clinicians. You're kind of reporting scans or doing things, but they're kind of doing their own thing. Whereas in GI, every day, they're coming and chatting to us, asking, can you show us this scan? Can we look through this?
Mhm.
Or can you come to theatre, help us with an ultrasound of a patient that's on the table, look for a lesion? It's just really nice working with them, and especially the gastroenterologists, doing a lot of Crohn's. We do a lot of Crohn's imaging in our centre, so it's quite nice working with them. They do a lot of research, and they're a really nice team. That's the reason. They're friendly sort of team to work with.
So you're doing GI and then hepatobiliary, and you were saying how you go in and you do like ultrasounds and stuff. Are you hands-on in other areas? Like, do you go into say like the X-ray department and do fluoroscopy for like upper GIs and
Yeah.
barium enemas, which I feel like in America not completely obsolete, but
We do. I haven't done an enema for it. When I started training, I did sort of 2-3 enema lists a week, and now it's completely gone. It's all CT colon now. So no, but I do go in a lot. I tend to go in probably more than some of my colleagues. We all have home computers, so we can all work from home and do it all remotely as well as go in. But within our team, we have a team of about 10 people in GI HPB, and we all go in. We all do a bit of fluoroscopy, ultrasound, intervention. We all do non-vascular intervention. So we put in gastrostomy feeding tubes, NJ tubes. We also help with the on-call with nephrostomy exchanges, and any drains, any biopsies, we do all of that. So we do that as well as do the sort of the diagnostic side. So it's quite nice to get a nice mix. Quite well at MDT. So when you're discussing the cancer patients at the meeting, rather than ask someone else, you can say, yeah, you can biopsy that, or you can drain that, and then you can arrange it, and then the next day do it. So you don't have to refer to colleagues. You can just kind of do everything within the team, which is nice.
yeah, and that you don't have to wait for like say like the interventional department to get back to you. Can they get this patient on like
No, so we don't do the vascular work. We have a separate vascular intervention team do the EVARs and all that sort of stuff. So that obviously refer to them for that. But most of the sort of body abdominal stuff we'll do.
That's nice though. I mean, and you're in control of your schedule and we can just do it tomorrow. So that's great for patient care that you're not waiting to when can this be done and stuff.
We have huge issue with shortage of radiologists in the UK. We do have some backlogs for reporting, which is really not great. But we do prioritise the inpatients and try and get them done really quickly. So the inpatients, same day they come down, we get the training, sort it all out really quickly.
So with GI imaging, do you like are there any challenges that you feel like that you face with it? Maybe doctors don't order them properly or a proper study's not ordered or you know what I mean?
Yeah, okay, yeah, kind of. We're quite firm with our clinicians. If we get a request that's not great, we'll just say no and throw it back to them and say, what do you want here? Or email them, or just say, look, I don't know what you're asking for here. Can you kind of tell us and explain? Or so we don't just accept things. Just if they we don't accept sort of they've got some pain here, do a scan. So we wouldn't do that because it's not very helpful. But they're generally very good, and they know that like, the better the communication with us, the better we'll communicate with them and give them the answer that they want, rather than sort of a vague descriptive report. We can go straight for what they want to look for, which is nice. Yeah.
Also too, like maybe from the equipment standpoint, like do you find that maybe you're looking for something specific and you find that you hit a challenge of what you're looking for, or maybe the type of scan that you're looking for?
Yeah. Yes, that happens sometimes, but we have access to MRI, CT, for all the things that we need. So sometimes we'll do a test and it's not right, and we'll say, actually, you need to get an MRI, and they'll book an MRI, and then we'll do an MRI. Or sometimes we just change it and just do it. It depends on the referral. We're quite flexible, so some people might request an MRI when actually they need a CT. So we'll just change it to a CT and say, look, we'll just change the CT. And our clinicians are very happy with us doing that and kind of choosing the right test for whatever the question is. So it works quite well. Rarely get into any sort of conflict. There's not like, oh, I want this test, why can't you do it? Because we always say, no, explain why, and this is the better test, do this one and why, and everyone understands. It works really well.
Looking at like CAT scan versus MRI, is one better for certain diagnoses or diseases than others? Because the cross-sectional anatomy, I mean, like you have it both, but the images are
Mm.
different.
Oh, definitely. And there's a cost difference. So if you've got an older patient and you get the same answer, go for CT. If you have someone's younger, you want to avoid the radiation, you get the same answer, we go for MRI. But generally, they are different indications. Someone's acutely unwell, they're really sick, they've got bowel obstruction, they're vomited, they always get a CT. We don't want to put them in the scanner, the MRI lying down for a while. But if you're looking for Crohn's disease or you're looking for sort of fistulas or things like that, they're much harder on CT. So we do an MRI for them. It depends what the indication is. Certainly, rectal cancer definitely always get an MRI, much better than CT. But it depends. I mean, CT colons are fantastic for colon cancer. So we do quite a lot of CT colonography now. We have a good endoscopy service. So we do, they do thousands of colons a year, but I think we do about 2,000 CTCs a year, roughly. Some centers do a lot more, some centers do less, but we've got a very good endoscopy service. So we don't tend to do as many as some other centers. But yeah, we find that quite rewarding. We've got a really good advanced practice radiographer team doing our CT colonographies. So we've got a team of, I think, 7 radiographers that are all trained up to do the examination, put the tube in, they do the provisional report as well. So they do an initial report of the colon and the findings, and then the consultant checks it and goes through it again.
Okay.
But training them up and doing that has been a fantastic improvement to the quality of scans, and getting the service done has made a big difference.
This episode is brought to you by xraytech.org, the RadTech career resource. If you're considering a career in radiology, check out xraytech.org to get honest information on schools, degree options, career paths, and salaries. I'm sure this is a more in-depth question than maybe we want to have, but what is it between CT and MRI imaging that you had said, like MRI is better for rectal cancer, but CAT scan is better for colon cancer? What is it between the images that makes one better than the other for those?
That's a good question, isn't it? It's just the resolution, isn't it? Yeah, so it depends what the question is. For rectal cancer, you want to know in detail how far the tumor is invading through the wall of the rectum. And you can get that detail with MRI. We do lots of sequences, and with CT, you just get a snapshot and it's just grey on the fat, and you can't really see the layers of the wall. On MRI, you can see the individual layers of the bowel wall. You can see the muscularis on the outside, the submucosa, and then the mucosa. You can see how far the tumor is going through. It's much easier to see if the tumor is invading into veins, which is really important, or if it's going to lymph nodes. And you can see if there's enlarged sort of abnormal nodes at the side of the scan. And it's a lot easier to do that with the MRI than the CT.
Didn't realize that the image was that different in terms of that it was more in depth, that it shows more information just in a different way. That CAT scanner would just turn up looking gray. It's interesting.
Yeah. So CT is better for loads of things. The resolution of CT tends to be pretty good, but the MRI of the rectum, it's really good resolution. And you do lots of views as well, and you align the scan with the plane of the tumor. So you can see they get really nice cross section, which you can't always get with the CT. So no, yeah, it's just different. We have a lot of protocol-driven stuff. So, for this, you have this, for this, you have this. So it's very clear, like, what scan we do for what indication, usually.
Do you help write the protocols for the department?
Yeah, so we do. We work with the radiographers to get the protocols. And in fact, my colleague this afternoon, was doing a list of small bowel MRIs on the scanner to kind of get the fat saturation sorted out, because it's not our fat saturation on our small bowel MRs is needs a bit of improvement. So hopefully we've done that this afternoon. So that's good.
Do you go back and review your protocols like maybe once a year to see if they need to be changed or if they can be improved?
We probably should do. We kind of review them as we go along, and like if we notice something, we'll then work on it and improve it. So we tend to it tends to come in bursts, and then we leave it for a few years, and then and usually it's when we get a new piece of kit. So certainly when we get a new scanner in, like obviously everything's different sequences, you have to kind of change everything. Or if this new evidence comes out, there's a new sequence, and we'll put that in. But we do a lot of small bowel MRI. I don't think you have so much Crohn's in America. I don't know if that's very common or not,
I
but
think that it is. I've worked in a few different health systems and, there's fair share of patients that you would see come into the ER, especially the first
mm,
hospital I ever worked at was a smaller hospital. And you would have same patients come in, quite often who would come in for like flares of Crohn's. And I feel like it
mm.
was pretty common that, and then they would have to stay and then they were constantly getting obstruction theory.
Oh, that's cool. Yeah, I mean, 'cause that's one of the things we're doing is we've added some motility sequences on the MRI. So it's been that for a few years, where you're looking at the movement of the bowel, a bit like the cardiac sort of cine images. So
Okay.
you do so. I think it's over 20 seconds. You see a 20-second snapshot of all the bowel movement, and it's really good because the bowel tends to move when it's normal. When you got the Crohn's, it just doesn't move, and it's really stark a lot on the images. So we've been doing that, and that's been quite helpful. So it's the sequences, things like that, that we add in and try and help us.
So, going to transition real quick from you being an attending there at Nottingham, but also to you being in charge of something that you also to author many textbooks. You're like a jack of all trades here.
I did them a little while ago now. Yeah, I've just got a 4-month old, so I don't have any time to do anything like that anymore.
Oh, congratulations.
Yeah, thank you.
What type of textbooks were you helping editing or writing, I guess, really?
Yeah, so I did a book on chest X-rays. It's called Chest X-rays for Medical Students, and I started that when I was at med school. Actually, we didn't really have a teaching resource, and it was for the medical school. And then I took it to the school to print out, and they said, "Oh, why don't you try and get it published?" So I did that, and a few years later, got it all. It was great. Got a book, and I like working with Photoshop and doing things. So I took the images and was coloring them in and adding everything. And it was quite novel at the time. Again, now it's all over the internet. Everyone does this now. But back then, back in 20, was it when that was 2009? It was quite novel, and that did really well. It's a sort of very basics of chest X-ray interpretation with kind of all the different conditions and a little mnemonic to go through. And I did the same for abdominal X-rays. And it's funny because that came out 2016 and it's called abdominal X-rays for medical students. But nowadays we don't do that many abdominal X-rays. We did quite a lot back then, but now it's CT. We've replaced a lot of it with CT. I wrote the guidelines to change from abdominal X-ray to CT. So kind of did the textbook and then shot myself in the foot. We don't do them anymore. Maybe I'll look at the chest X-ray book again, but I think things have changed since I did that because nowadays there's so much stuff online that you don't need that many textbooks anymore.
Yeah.
So back then it was you need the books. So I'm not sure if we did a second edition of the chest X-ray book, but I wonder if we need a third. To be honest, if they come to me, I'll probably say, yeah, okay, we'll work on it. But I'll be surprised.
I didn't know that maybe they could publish it that's available that you could get as like an ebook, kind of. You know what I mean?
Yeah, so it's available as an ebook, so you can get it as an ebook. But as I say, there's so much stuff online for free now that it has to be really good to kind of just. I think it is really good, but there's just so much stuff out there now. You're sport for choice now with all the different resources and learning resources. And wonder if we did another one, whether it would be sort of a website version or something. But yeah.
I personally have to say that I find, at least when it comes to school and learning, there's something very much like tangible about having a book in front of you, having a highlighter. That was the way that was good for me to learn. So, I mean, I love the internet. Like you said, it's a wealth of information, so much out there, but having a book in hand sometimes when you're learning something new, especially, is very helpful.
Yeah, I totally agree with you. Totally agree with you. I'm just not sure that I represent the new guys coming through now because they're so
Yeah.
used to technology. They're just different. I maybe they still go for book. I don't know. But yeah, we did so on Radiology Cafe. I have loads of physics notes for the whole curriculum for the physics, and we made them into a book. And you can get that as a book, and people do buy that. I do think that there's certainly something in it that you say, as you say, having it on paper and highlighting it does make a difference. I find it much easier to learn that way and remember stuff.
So another thing I want to discuss that, that you have your hand in, Rankin Fest. So this is a conference that you helped start up, or were you the initial person behind it?
I wasn't actually. No, this is one of my colleagues, Chaka Kennedy. It's her brainchild. So it's Röntgen Fest. It's named after Wilhelm Röntgen, who obviously discovered X-rays. This is a bit of a play on his name, and it's a local sort of regional academic research meeting that we do in Nottingham, mainly for our trainees, so they can share all the audits and all the research they've done over the year and present them to others, so we can all share, and also just get out of the hospital for a day and have an environment where the consultants and the registrars or the attendings and the what's the word for the registrars in America? I forget attendings and
Residents.
residents. That's the one. Yeah, sorry, don't use that at all in the UK. Where they can kind of mix and chat and just informally. And we invite all the hospitals in the region, so it's quite nice. You see colleagues that you don't see very often. So Chaka started it about 10 years ago, and then she stepped away about 7 years ago, and then I took over. sort of chairing it, and we go to sponsors to get the money to pay for the event. So we've managed to do it for free for the last few years for everyone, for lunch and food and things paid for by the sponsors who kindly come, and we get 5 or 6 to kind of sponsor the event. And it's really good fun. I did it for the last time last year. I did it for 4 or 5 years. I had to step away because I'm too busy with other stuff now. So I've handed over. But yeah, definitely worth doing. Really good to kind of, I think sometimes our trainees don't get exposed to research enough. So it's really good to get them to see like examples of really good practice so they can share, okay, this is what I did. And sometimes all the pathways are very different for different consultants. And you can see like, okay, I didn't do a PhD, I didn't do this, but this is how I got into research. And I did this project, and we kind of get them as role models, to present to the trainees to show them this is what you can do,
Mhm.
and that's quite good.
I was looking on the website and I found it interesting that I guess you guys try to keep it light a little bit where you do different awards for people that are there
Yeah,
for
yeah,
research. I saw the different names. I feel like some of the names were kind of like playful for the awards. You do awards in
no,
general though, which is nice.
we
And
do awards. Yeah, we didn't. I don't think we have played for names. I think they're really boring names. Actually, we had an e-poster award and the research award for best audit and quality improvement. But yeah, no, again, the sponsorship pays for that, so it's a couple of £100, and then I think it's £400 for the research award. And actually, that research award is not paid for by the sponsors. That's a grant that we were given by the family of one of our registrars that sadly died a few years ago, and they left us quite a lot of money in a charity to support research. So every year we use a bit of that to pay for the research prize. It was quite nice.
nice. That's great. Do you know what the best research award was for this past year?
Oh, now you're asking me. I can't remember. They're all very good. That's the answer, isn't it? They were all very good. It,
Okay.
it, it, we choose the best. The abstracts are submitted. We choose the best 4 to do an oral presentation using sort of 3 or 4 judges. And on the day, we just pick 5 or 6, sorry,
Okay.
3 or 4 consultants to judge, and then
Okay.
they will just pick a winner on the day. So it is based on just who does the best on the day. So it's quite good. It's kind of even playing field.
Have you ever been a part of the Rankin Fest?
Yeah, actually, yes. I think I got one of the prizes for one of the audits, when I was a trainee, back in the day. But yeah, no, it's just a nice way of recognizing like the achievements that the registrars do. They don't often get that. They're so busy working and doing things, it's quite hard to. So it's nice to have a day where they can just celebrate them. And we mix it with education. So it's not just all audit research, it's kind of 50-50 audit research, so 50-50 people coming in and giving educational talks and they're teaching. So it's so the consultants also get something out of it as well as as seeing all the research that's going on in the region.
So kind of switching from research, which, finding out all new types of information from the registrars and then at the Rankin Fest, kind of looking into the future in terms of like imaging and equipment for the world of radiology. Is there anything that you have like had your ear down to the ground that you've possibly heard about, or maybe something that you're thinking in your mind that would help aid in like GI and hepatobiliary imaging?
Plus, there's a few things. I think apart from obviously the AI, we'll see how that goes. We're doing a few projects on that, but I think that'll take a little while to get in. The photon counting stuff that the Siemens are doing with CT scanners is really, really good. And I'm sure the other companies are all working on stuff at the moment that's similar. And I'm quite keen to see where that goes with the fluoroscopy, with intervention, because I think as soon as we get that technology in the detectors, which hopefully won't be too far off, that'll be a step change. And hopefully, I'm hoping that will lower the doses. I mean, we could do a lot more things, give us much better image quality and help, particularly some of the vascular stuff, I suspect.
So what
Um,
exactly would the photon counting do? Like, explain that to me because I mean, I
I
know
don't know.
I know what photons are. I'm sorry to get really technical, but I'm interested
Yeah.
because you said it's going to be a really good development. I know personally what photons are, but when you say photon counting, I don't know. I feel like I'm like,
So there's new CT scanners now that are really, they look at the energy of each individual sort of photon. This is my understanding. I think if a physicist is listening, they're probably going to be like screaming at me, in the camera. But with my with my radiology hat on, I'm not a physicist. But my understanding is that the detectors are much more sensitive. They can detect not just individual energy of each photon, which means you get a lot more information, you get a lot more signal, which means you can lower the dose or get a lot better resolution. And either one of them is great. And I know that they've got this technology in CT. I don't fully understand it, and maybe it won't work in other modalities, but I can't see why someone clever can't, put it in an X-ray detector, and that will make a big difference. I think, hopefully, particularly from the high dose fluoro stuff we do. So I'm
right.
really keen to see which companies come out with that and what they do with that, because I think that'd be really great.
So basically, still producing a great image, but lowering the patient
Yes.
and then lowering the dose for the doctor and the technologists that are within the room. during a
Yes, lowering the dose, or you have the same dose but much better resolution.
Okay.
Either one has sort of benefits depending on, yeah.
You heard that Siemens is developing something like this?
I'm aware that they've got the photon counting CT scanner,
Okay.
but I don't know if other CT scanners do it, but I'm sure the other companies are working on it, so it's like with everything in radiology, one company does it and a few years later everyone else follows suit. So I'm sure it'll be the same.
They
Yeah.
just try to do it just a tad better if they can, but yes, that everyone jumps on the bandwagon.
Yeah, I'm sure there's stuff that's been working on at the moment. But I've only heard of it in CT, but I'd be amazed if there's not plain film and fluoro stuff coming out in the very near coming months, or probably unveiled at RSNA come December.
Right. Yeah. Always new great developments coming out from different conferences like that. All right, everybody. Well, this is Chris Clarke with me discussing the realm that he's in, GI, hepatobiliary, being an attending or consultant, as I learned today, and all the different things that he has going on while he has a baby as well. So, Chris, thank you for taking time out of your busy schedule to be with me. I really appreciate it.
Thank you. It's wonderful to be here. Thank you.
And everybody, we'll see you next week. Make sure you check out other episodes and future episodes. Leave us some reviews so we know what you think. And we are on Apple Podcasts, Spotify, and then also YouTube. You can find us. So, all right, this is Jen and Chris, and we're out of here for the day. You've been watching The Skeleton Crew, brought to you by xraytech.org. On the next episode, join us to explore the present and the future of the rad tech career in the field of radiology.